Hey, how's it going, everybody? This is Cole. Welcome back to another episode of Pathagonia. So, Dr. Schauberg just posted some new updated notes on the appendix. You can find these at his website, which I'll link in the comments or the description of this video. And highly recommend you check out Kurt's notes. It's an excellent resource for pathology, for residents, medical students, and even, practicing pathologists. So we'll go ahead and get started. So the first section is on inflammatory or non-neoplastic entities of the appendix. So first we have the classic and very common diagnosis you'll see on SearchPath, acute appendicitis. So it's extremely common. It's the most common abdominal surgical emergency. It's often diagnosed clinically, can present with colicky periumbilical pain, which localizes to the lower right quadrant, and it's treated with an appendectomy. So basically you just take out the appendix. Histologically, you're going to see acute neutrophilic inflammation. There's no strict criteria or cutoff, but generally the acute inflammation goes into the wall. And if it goes to the serosa and the mesoappendix, it is called periappendicitis. If it's solely periappendiceal, that would suggest an extra appendicular cause. So if the inflammation is only on the outside surface of the appendix and not within the appendix itself, that would indicate some other source of infection in the peritoneal cavity could be causing the inflammation. When you're evaluating appendix for appendicitis, don't forget to look for tumors. Especially in the tip, you can classically see a neuroendocrine tumor, amongst other things. And then this is what it may look like at low power, and then you can appreciate a lot of neutrophils, a lot of acute inflammation here at higher power. Alright, next up we've got interval appendicitis. So some often ruptured cases are treated with antibiotics in the acute setting and then may be treated with appendectomy after some interval of time. There's minimal acute inflammation. You can have granulomas, xanthogranulomas, chronic inflammation with lymphoid follicles, and fibrosis. Next up, we've got granulomatous appendicitis. So as the name would suggest, you have granulomatous inflammation, which can be infectious, caused by Yersinia, mycobacteria, fungal, or parasitic, or non-infectious causes such as Crohn's disease, sarcoidosis, interval appendicitis, foreign material reaction. So if you're seeing granulomas in the appendix, be sure to do bug stains to rule out infectious causes. There's a relatively low risk of developing Crohn's disease if isolated to the appendix. Next up, we've got a diverticulum. So a diverticulum is usually acquired pseudodiverticula, which is a herniation of the mucosa through the muscularis propria due to increased luminal pressures. So you see here, if you have increased pressure, it could cause that to pouch out, causing a diverticula. And if it can become inflamed, leading to acute appendicitis. So the diverticula is lined by normal appearing epithelium with lamina propria, and it can rupture and extrude some mucin, so don't confuse this diverticula with a lamin, which we'll get into in a couple pages. Lastly, on this page, you can have a retention mucocele. This is when you have a luminal obstruction leading to retention and accumulation of inspissated mucus, which leads to dilation of appendix. Think blowing up a balloon. And then it's unilocular, thin-walled, lined by flattened, atrophic, or smushed epithelium. And you can have myxoglobulosis, which is a variant of a mucocele, with mucinous, occasionally calcified pearl, or caviar-like globules. Moving on. So this is something that may come up in your sign outs. I've definitely seen it, and I've had colleagues Some of my co-residents show it. So it definitely comes up. So you can have fibrous obliteration. Very common, usually found incidentally. And what it is just replacement of the lumen by fibrous tissue with varying neural proliferation and adipocytes. So it may stain with S100. All right, now we're moving into the neoplastic territory of the appendix. So for tumors, you can have serrated lesions and polyps. So they're identical to those seen in the colon, but good review nonetheless. They may be incidental or cause acute appendicitis, and they are associated with KRAS mutations. You can have a hyperplastic polyp, which is a polyp with serrations of the superficial crypts only. And then if you have a sessile serrated lesion, formerly sessile serrated adenoma or polyp, is a serrated polyp with distortion extending to the crypt bases, often circumferential, and it can develop adenoma-like dysplasia with high-grade or low-grade, villous growth, and eventually lead to possible adenocarcinoma. Notably, both of these lesions have intact lamina propria, in contrast to a lamin where it is compressed and disappears. So on the image here, I have a hyperplastic polyp because you see the serrations, but it's only at the surface. If it was a sessile serrated lesion, you would have dilated crypts all the way down to the base, with classically like that booting that you would commonly see. So this is a hyperplastic polyp. All right, next entity we have is adenocarcinoma. So it looks just like adenocarcinoma of the colon, but it can be not otherwise specified, mucinous or signet ring, amongst other variants. Adenocarcinoma of the appendix frequently has a KRAS and GNAS mutations, and staging is very similar to colonic adenocarcinoma. There are irregular malignant glands infiltrating the stroma, often with a desmoplastic response, as shown here in this image. Next up, you can have neuroendocrine tumors of the appendix. So this is the most common appendiceal tumor by far. Incidence of about 1% of all appendectomies have a neuroendocrine tumor in them. So majority are in the appendiceal tip, so be sure to sample the tip. They often occur at a younger age than neuroendocrine tumors elsewhere in the GI tract, and they may present incidentally or with acute appendicitis. They have a good prognosis with over 95% survival if they're confined to the appendix, and looks and is graded like other GI neuroendocrine tumors, and you can see a separate guide for that grading. So histologically, you're going to see nests and cords of cells with monotonous nuclei with salt and pepper chromatin. Next up, we have some unique appendiceal tumors. So you can have appendiceal mucinous neoplasms, or lamins and Hammonds. So a lamin is a low-grade appendiceal mucinous neoplasm, which has villous mucinous epithelium with tall cytoplasmic mucin, with low-grade cytology, which are nuclei compressed to pseudostratified in appearance, with broad pushing border with compression of the lamina propria, and obliteration of the muscularis mucosa and fibrosis. Mucin may dissect through the wall with or without epithelium, and lamins can cause Pseudomyxoma peritonei, which is on the next page. And the prognosis is very stage dependent. Earlier is much better. If there is intact lamina propria, some call appendiceal adenoma. And you can also get a Hammond, which, as the name suggests, is a high-grade appendiceal mucinous neoplasm. Similar to lamin, but with additional complex architecture, such as micropapillary or cribiform, and or cytologic atypia. Staged as an adenocarcinoma, CIS, but behaves like a lamin. So some images we have here. This is a lamin with that low-grade pseudostratified pencilate hyperchromatic nuclei that kind of remind you of a tubular adenoma that you may see in the colon or an adenoma elsewhere. Whereas in the Hammond, or the high-grade appendiceal mucinous neoplasm, you have very scattered architecture, complex architecture, and very abnormal cytology. If there's infiltrative growth, then that's going to make it an adenocarcinoma. So both the Lamin and a Hammond have frequent KRAS mutations, and both are considered in situ. So PTIS, Lamin, is how it would be signed out, or for staging purposes. And if it's confined by the muscularis propria, it can recur if perforated through. If through the muscle into the subserosa, it is staged as a PT3, and if the serosa is involved, it's a PT4A. If there are acellular peritoneal deposits, that is considered lower risk and would be staged as a PM1A. And if there are cellular peritoneal deposits, that's a higher risk, and that would be PM1B. So you must sample the mucin well. And in the image, you see some mucin here on the left, and then this neovascularization on the right. To consider something as a true extraluminal neoplastic mucin, and not just artifactual grossing contamination, you'd ideally like to see dissecting or infiltrating mucin with neovascularization and tissue response, as shown in the image above. So here's a nice chart that kind of compares the features of a Lamin or a Hammond versus mucinous adenocarcinoma. So cytologically, you're only going to have high grade for mucinous adenocarcinoma, where obviously for a Lamin you can have low grade. There's going to be complex growth for adenocarcinoma and a simpler growth pattern for, at least for the Lamin. The Hammond may have more complex architecture. You may see signet ring cells in adenocarcinoma, but typically won't see them in Lamins or Hammonds. And Lamin and Hammond will have pushing invasion and no dysplasia, whereas a mucinous adenocarcinoma will have infiltration and desmoplasia. And then remember, for a mucinous adenocarcinoma, you can see tumor cells floating in the mucin, and there's risk of lymph node, systemic, and peritoneal metastases. And you would want to consider chemotherapy and possible hemicolectomy for lymph nodes in adenocarcinoma. For a Lamin or a Hammond, there's often no or rare small clusters of tumor cells floating in mucin. And you can get peritoneal disease, but there's no lymph node or hematogenous metastases. And you want to just follow them with imaging and possibly a cystectomy. Alright, as previously mentioned, you can also get a Pseudomyxoma peritonei. So these are deposits of tumor with abundant mucin within the peritoneal cavity, secondary to a mucin-producing epithelial neoplasm, usually of appendiceal origin. Grossly, they're going to be gelatinous, watery globules, leading to what is known as jelly belly, and they're graded as G1 through 3, as shown below. And if there's more than 10% signet ring cells or sheet-like growth, that's going to be a G3. So a G1 is shown in the top image, G3 below. And then if you want to reference this table on your own, I'm not going to belabor the point. It's very similar to the last table, so good thing to reference and take notes on. The features that would distinguish low grade or G1 versus high grade or G2. And our last entity is goblet cell adenocarcinoma. So this was previously known as goblet cell carcinoid or adenocarcinoma x goblet cell carcinoid. And histologically, it's an amphicrine tumor with goblet-like mucinous cells, endocrine cells, and Paneth-like cells. And amphicrine refers to having both endocrine and exocrine features. So you must have at least some low-grade pattern for the diagnosis, otherwise just call it an adenocarcinoma. and it's usually located at the appendiceal tip, and it's staged as an adenocarcinoma. So for the low-grade pattern, you're going to have tubules and clusters of goblet-like mucinous cells with endocrine and Paneth-like cells with granular eosinophilic cytoplasm, mild nuclear atypia, and no stromal reaction, as shown in the image above. Whereas for the high-grade pattern, you're going to have tumor cells infiltrating as single cells, complex anastomosing tubules, cribriform masses or sheets, and signet ring cells, as well as high-grade cytologic features and a desmoplastic response. So for a goblet cell adenocarcinoma, for the grading, a grade 1, you're going to have tubular or clustered more than 75%, which is a low-grade pattern, and you're going to have less than 25% high-grade features or loss of tubular clustered growth in a G1. For G2, you're going to have 50 to 75% low-grade pattern, 25 to 50% high-grade, and then for G3, you're going to have predominantly or more than 50% of that high-grade pattern. So that's it, just a quick review of the appendix, and I hope you all have a good day. Thank you.